Okay, students, because I did not get into or was not able to finish the PowerPoint lecture from class on Thursday, I'm doing a recording of the remainder of the PowerPoints. So we kind of stopped on hydramnios and oligohydramnios. So hydramnios, which means too much fluid, or you might hear people call it polyhydramnios, is a fluid level, amniotic fluid level of greater than 2,000 cc's. So we know that the fetus swallows and inspires fluid. The fetus urinates. That helps kind of maintain the balance of the amount of fluid needed in the amniotic sac. Things that affect that would be any type of fetal malformations that affect swallowing, so they're not able to swallow, or they're not having inspiration movements, okay? So neurological disorders where the meninges are exposed can help or can contribute to abnormal fluid volume levels. Patients or mothers with diabetes, if there's an RH sensitization, multiple gestations, and infections will also affect the fluid level. So if the hydramnios is severe enough, we may need to do amniotic fluid reductions. Now, we have done this at Community Medical Center. I don't know if it was last summer or the summer before. And I'm sorry, I can't tell you what it must have been last summer when I stopped working there, because I can't really tell you what was going on with the fetus or the mother. I do know that this gal, like twice a week, had amniotic fluid reductions. So she, there was just massive amounts of fluid production. They took off liters and liters of her every couple of days. It was crazy. So anyways, how they do that is through amniocentesis. So with an amniocentesis, we usually go in and just get a fluid sample for testing. But with this case, we did an amniocentesis and we withdrew liters of fluid off of this woman. But anyways, hydramnios can certainly cause shortness of breath for the mom, as that uterus becomes so enlarged, starts pushing on the diaphragm, and causing her inability to take a deep breath. Okay, it also compresses the lungs, so it's just a whole terrible scenario. And then the lower extremity edema is caused by the weight of the uterus on the vessels that drain the lower legs, and so they don't get drained. So here's your risk factors. And of course, for a baby, whatever's causing baby to not be able to maintain adequate or the proper amount of amniotic fluid, so that baby has those problems. But in addition, the weight of that amniotic fluid could induce a preterm labor, so that's also an issue for the baby. Now, oligohydramnios on the opposite side of the extreme is not enough amniotic fluid, so less than 500 cc's of fluid. And there are pockets. So with baby in there and the placenta in there, there are pockets of fluid. And so anything less than 5 centimeters, they measure that on ultrasound, is also considered oligohydramnios. And this is usually attributed to some sort of fetal renal malformation. Okay, so the fetus is not urinating correctly or enough, so something's wrong with baby's renal system. And it's also linked to intrauterine growth restriction. So in labor, for the mom, other than the problem for the baby, this really creates no significant problems for mom, except for she will have a dysfunctional labor. Okay, so there's your fetal risks. Fetal and skin abnormalities, pulmonary hypoplasia, because baby is not breathing in or inspiring in enough amniotic fluid. And of course, there's the common cord compression that we see with low amniotic fluid. And then fetal adhesion. So amniotic fluid is a lubricant, and if there's not enough fluid in there and those developing tissues of the baby, two opposing places are touching, then that can grow like that, adhere together and grow like that. So that could be a problem for baby as well. So with oligohydramnios, we'll do our NSTs, we'll do our biophysical ultrasounds, our biophysical profiles, we'll do serial ultrasounds. We're just continuing to keep track on the fluid level. We may end up having to induce labor. And then when they are in the hospital, they are on continuous monitoring. And if their bag of waters is broke, we will possibly do an amnio infusion. And that is, we use the intrauterine pressure catheter, the internal catheter that goes in the uterus that we use to monitor contractions. There's a port that we can infuse fluids. And then, of course, we'll be repositioning mom, because oligohydramnios can cause variable decelerations, and also mom will be on IV fluids. Okay, so now we're going to talk about labor-related complications. So that's tachysystole, which is too many contractions. So we'll define that, a hypotonic labor pattern, and then our therapies and our nursing care. So when we talk about a dysfunctional contraction pattern, we are deciding whether or not we have adequate contractions, an adequate pattern, or whether we have too many or too little. Okay, so if we have an adequate pattern, we've got contractions at 2 to 3 minutes apart. We have 5 contractions in 10 minutes. If we have more than 5 contractions in 10 minutes, we have tachysystole, and that's what the number B strip is. That's tachysystole, and those contractions are closer than every 2 minutes. Okay, and then the strip on C is the hypotonic contraction, dysfunctional contraction pattern. She's not really contracting well enough at all. You can see 2 on there, around 1 minute and 8 minutes, that look like, they may not be a decent strength, but they look like contractions. All those little things that are going on in between those, like around between 3 and 4, between 4 and 5 minutes, at 6 minutes and 7 minutes, and so forth, that's what we call irritable uterus. So her uterus is cramping, maybe even quivering in a sense. It's just irritable. It's just cramping. They're not focused contractions. Okay. So with a systolic pattern, of course we're going to have discomfort and fatigue. She's contracting every minute. So this is going to be a bad situation for mom. It's going to put baby at an increased risk for a non-reassuring heart patterns. Okay. So bed rest and sedation. The meds we give for sedation relax muscles, so that might help in spacing out those contractions. If she is on Pitocin, we need to be turning it down or turning it off. And then if a vaginal birth is not possible, of course, we need to stop whatever we're doing or stop her contracting. If we need to stop the Pitocin or give a tocolytic to stop her contractions, so we can go to C-section. Okay, so here's some of our nursing care. Of course, we're going to assess the contractions, the fetal heart rate pattern, mom's vital signs, provide comfort, all these kind of things, help with pain. Okay, so the hypotonic labor pattern, that was number C on the previous slide, where the uterus is just really not contracting effectively, or it's not even contracting at all. It might just be irritable. We see this with an overstretched uterus. She's got hydramnios, a twin gestation. She's got a macrosomy baby, which is a large baby. Baby is positioned in there in such a way that it's not allowing those muscle fibers to contract correctly. She's got a full bladder or bowel and a cephalopelvic disproportion where the head is disproportionately large to fit through the pelvis. So this labor could go on for hours and hours, and I kid you not, days and days. This is how women died back in the day, is they never contracted well enough to dilate and deliver their baby. So if she does happen to make it to delivery, then that hypotonic uterus during labor is going to be a hypotonic uterus after delivery. So she is going to be at huge risk for postpartum hemorrhage. Okay. All right. So now we'll move on to the nursing. Well, actually, I don't think. Yep, I do. Nursing care of the post-term baby. So you would think that preterm is bad, term is good, so post-term is better. So we've got a really, really healthy, mature, fat baby. Not the case. Okay. So anyways, women who are post-term are going to probably end up being induced, and that carries its own risk factors. She's going to have a dystocia is a difficult labor. She might have a large infant. She might end up having to have a forceps or vacuum because of the large infant. Okay. Of course, that's if she does end up having those things, or even if she doesn't have a forceps or a vacuum, if she has this large baby, she may very well cause an injury to her perineum. Okay, she's at risk for hemorrhage, and of course a C-section delivery if she can't get this baby out. So for the baby, the big thing is decreased placental perfusion, uteroplacental perfusion. So the placenta is only designed to live for approximately 40 weeks. So if we've got a post-term, a 42-pluser week gestation, then that placenta is starting to deteriorate, and its function is also deteriorating. So that does put baby at risk for demise if that placenta just stops. If that placenta stops working well enough that there's no good gas exchanges. Okay. Oligohydramnios, of course, because things are not functioning, and everything is just diminishing. Okay, so we have all these risks for our baby. Now, macrosomy, or a large baby, is a risk. You would think that the longer the baby is in there, the more the baby has the ability to grow and gain more weight. However, if we have a uteral placental insufficiency where we're not getting nutrient and gas exchange to the baby, then your baby will start losing weight. Okay, so you might have a small for gestational age baby, which will bring its own problems. And these babies look like little old men when they're born. So we do, we keep monitoring the baby. The more term they get, the more they get to 40 weeks and beyond, we start doing more regular fetal well-being checks. So the NSTs and the biophysical profiles. We'll even try a contraction stress test to see if we can induce this person, if baby will tolerate it. Okay. So now for fetal malpositions or malpresentations. So a malpresentation really is anything other than an OA presentation. They can be a right OA or they can be a left OA, but OA is the important denominator. Okay. If they're occiput posterior or OP, that means that their their occiput, or the back of the head, is facing the back of the woman, so the baby is facing forward, or what you've commonly probably heard as sunny side up. This baby, we can deliver babies vaginally that are OP. However, it is very difficult. The woman's contractions are more painful, especially in her back, as that hard cranium is raking down her sacral and coxal muscles and nerves. It's more painful that way. Anyways, but she can still get it done. She just needs to push a lot harder when the pushing occurs. So the risks are POP is persistent occiput posterior. She runs the risk of having a very severe laceration, or if they did cut an episiotomy, that it extends, meaning that it tears more than the episiotomy was intended to reach. Okay. All right, and then of course, again, forceps or vacuum, that creates risks for mom, and that creates huge risks for baby. So close monitoring, and also we like to try to really reposition these women a lot, even to the hands and knees, to try to see if we can get that baby to turn. But anyways, we need to decide whether this baby can come out vaginally, or whether we feel like a C-section is warranted. Okay. All right, so here's talking about how we can move mom from side to side. She can be knee to chest, like she's laying on her back and just pulling her knees to her chest, or the hands and feet are really helpful as well. I'm sorry, hands and knees, hands and knees. The Sims position. So if we do get baby to rotate back, a good way to keep baby in that position is to lay mom in the Sims position. So that's basically, so if you take a woman, I don't know if you guys are familiar with Sims position, but if you take a woman who's laying on her belly and hike up one side of her hip and put pillows there with that higher leg bent, and the arm that's down against the bed, it's laying down behind her. That kind of secures the baby in the position that it rotated in. So hope that can be helpful as well. Now, a manual rotation during labor is extremely difficult. The physician, depending on how low the baby is, how strong the woman is contracting, the physician will be working against that power. So it's pretty difficult. So anyways, a lot of times what we end up doing is upsetting baby enough that fetal heart rates start being unreassuring, and we go to C-section. So again, the occiput is the normal presentation. Even if you have a head down, you may have not the occiput, but you may, when you do a vag exam, you may feel the brow, the face. You may have a breech presentation, and then you may have a shoulder presentation, which is a transverse lie. Now, I threw this in here. If we're laboring a patient that has a brow or a face presentation, we do not put spiral electrodes on brows or faces. We only put them on the baby's head, okay? And of course, not a breech, so we won't be putting a spiral electrode on a baby's butt cheek. So this is kind of the normal way we want baby to come through. So this is the diameter of, if the head is coming down correctly, this is usually the biggest diameter that head has to come through the birth canal. So you can see that this diameter this military position where you do have the head coming down, but it's not the occiput part of the head, it's the top of the head. So you can see how big this diameter is compared to this occiput presentation. And then here is your brow presentation, and look how much, well, actually, they're measuring from the chin to the occiput, but what you're going to be feeling when you do a vag exam is the brow, okay? And then here's your face presentation. Now, this is about the same as the occiput presentation, but look at that baby's neck and what trauma and damage we can do to that if that baby delivers that way. And then also, what damage can we do to the cervical spine and all those nerves and tendons and ligaments, okay? And then here's your breech presentation. Now this is called a frank breech because it is total butt. The feet are in the air, or not in the air, the feet are up, and it's total butt coming through there. And this is a footling, what they call a footling or an incomplete breech, where the feet are coming first. All right. We don't want to be delivering breech presentations, if at all possible, because of the risk of the baby's head getting hung up in the cervix, and then causing, that's a problem. And then what kind of damage are we going to be causing to baby trying to get that head dislodged? Okay, so if a patient is breech, hopefully we catch this like really early, like 35, 36 weeks. The earlier we catch it, I mean, we don't want to be doing this at 34 weeks or 32 weeks. We want to do this close to delivery, but not so close that we don't have room to move this baby. So we like to do it between 36 and 37 weeks. We do this cephalic version, or external cephalic version. External meaning that the physician is trying to turn the baby with his hands on the outside of the mom's belly and trying to manipulate baby into a head down position. So if we have a shoulder presentation, then of course, if we catch it early, we can do the version. Even if we catch it during labor, we might be able to turn that baby, but the closer we get to labor, the more difficult this is going to be. You don't necessarily need an ultrasound to determine that the baby is breech or transverse. Leopold's maneuver is an excellent way to determine if baby is head down or if baby is transverse or breech. Sometimes, especially with a transverse lie, you can just look at her abdomen and know, I don't think that baby's sitting in there right. When we auscultate fetal heart tones, so if we use a Doppler or if we put the ultrasound toco from the fetal monitor on, depending on where we get those heart tones, we can kind of gauge where that head is. So the best place to pick up heart tones is over the upper part of the fetal back. So if the upper part of your fetal back is up around her fundus area, you can kind of think that maybe this baby is breech. If you're getting at the umbilicus area, then your baby is either breech or transverse. Usually if we have a cephalic presentation, we get the fetal heart tones down in the very lower quadrants of her belly, okay? And then of course we can do a vag exam, and if we can reach the presenting part, we can feel what that is. Is it a hard skull? Is it a soft butt cheek? Or is it a knobby shoulder? Okay, so this is what a transverse lie would look like. And you could see how, if you look at a woman's belly, how you might see this is occurring. Okay? All right. So, so let's talk about the macrosomic baby. So these babies typically weigh, or to be diagnosed as macrosomic, these babies weigh greater than 4,000 grams, okay? Um, they're at, of course, increased risk for CPD, and then the dysfunctional labor, prolonged labor, tearing up mom's bottom, and then the postpartum hemorrhage, remember, because the big baby causes that overstretched uterine muscle, and so it doesn't contract as well, okay? So postpartum, she might have a hemorrhage problem. So what are the problems for the baby? Well, shoulder dystocia. So what if we can get the head through? If we can't get the shoulders through because we've got these broad football shoulders, then we have a severe problem, okay? So shoulder dystocia is an obstetrical emergency. There is a protocol we follow to try to alleviate a shoulder dystocia, and within a few minutes, if we don't get that alleviated, we go for a stat C-section. But even if we get that alleviated, we might cause some trauma to the baby, okay? Now, hypoglycemia is another big thing. So when we have a large for gestational baby or a macrosomy baby, they fall under a hypoglycemia protocol, just the same as a baby born of a diabetic mother or an SGA preterm baby. They all fall under a hypoglycemia protocol, okay? And that is because, at least for the large baby or the gestational babies, because they're used to all this sugar from mom, and the baby is the one who produces the insulin to handle that sugar load, and then once they're delivered, they don't have that sugar load, but they have that insulin. So for 24 hours, we watch them, and within that 24-hour period, then they start producing normal amounts of insulin according to their intake. Okay, but we've got to get the rest of that mom's blood sugar out of there, so we've got to watch these babies really close. So they're under the hypoglycemia protocol. They get blood sugars before every feed. Okay, and these are, of course, the other problems for macrosomy babies. So, yeah, we want to identify a macrosomy baby, but if you remember from my lecture yesterday, I said there were, or did I say this? The ACOG, American College of Obstetrics and Gynecologists, they have put out criteria for induction, and specifically what is a maternal and an obstetrical reason for early induction, and macrosomy is not. Anyways, you know, we just identify these babies, we watch these babies, and do the best we can. So we can't induce them early, but we certainly could schedule an elective C-section, okay? But anyways, she can also have a vaginal birth, hopefully. That goes well. When we're talking about shoulder dystocia, there's a couple of the maneuvers that we, the nurses, help the patient and the physician do. There's some maneuvers that the physician can do, but the maneuver that the nurse does is one, she does this McRoberts maneuver, and that's when two nurses grab the mom behind her knees and pulls the woman's knees as far to her shoulders as we possibly can, as well as applying what we call suprapubic pressure. Now this is very critical, especially in your documentation, and especially in applying this, that you do it correctly. Suprapubic pressure is right above the pubic bone. It is not anywhere else on that abdomen. Okay? It's not on the fundus. It's not on her umbilicus. It's at her suprapubic bone. And we take our fist and we put pressure down on that suprapubic bone. The physician will tell us which way the baby's face is facing. And as we're pushing down, we push down and towards the way the baby's face is facing. We're hoping to squinch those shoulders anteriorly so that baby can now fit through the pelvis, okay? And that sets baby up for the clavicle fractures and the brachial plexus injuries and all those kind of things. So we need to be absolutely certain that we are not applying fundal pressure And when we document, we must document that we did suprapubic pressure, okay? And then the physician has other things he can do. He can reach in there and try to corkscrew the baby. He can try to grab the baby under the armpit. He can do, the physician can try all kinds of things. But if we can't get that out, then we go for emergency C-section. Okay? All right. Okay, moving on. Continuous monitoring, yes. Assessing her labor progress. And then when baby's born, we must alert the baby nurse. And she assesses baby for injury. And then, of course, the blood sugar protocol. Okay. Now, as far as the woman is concerned, remember, this is redundant, but I want you to know you got to be thinking about what's going on with that woman's uterus in pregnancy and labor, and what is that uterus going to do after she delivers the baby. So the overstretched uterus will not contract effectively, okay? So we have uterine atony, or a boggy uterus, a soft uterus, and we have hemorrhage. So first line treatment is fundal massage, as well as giving Pitocin IV. And usually, if she hasn't been using Pitocin in labor, our standard of care, our preparation for delivery is to have Pitocin ready to give her after delivery. But if something happens, she doesn't have an IV, she loses her IV, she comes in precipitous deliveries, we don't get an IV, or whatever happens, we can give Pitocin IM, okay? And there's other drugs that we give. We also give Methergin, IM injection, 0.2 milligrams. The physician can also give that intrauterine, so he goes right through the abdomen into the uterus. We can also give Hemabate and Cytotec. Hemabate's IM. Cytotec is rectally. So Cytotec comes in the 100 or 200 milligram caplets. We give 600 to 800 milligrams rectally. So if we have a 100 milligram tablet, we're given 6 to 8 tablets rectally. And then, of course, if we're giving a 200 milligram tablet, we're giving 3 to 4 of those. Anyways, this isn't a postpartum hemorrhage lecture, so scratch that, I guess. Anyways, okay, so what are we talking about here? So now we're going to be dealing with our non-reassuring fetal heart rate status. So signs of a non-reassuring fetal heart rate status are variations in the normal heart rate. So if your baby's running 120s for several hours and then all of a sudden now baby is running 140s, that's not terribly alarming unless you start seeing a trend, okay? But if a baseline fetal heart rate is within normal, then we're okay. But we might be seeing other patterns in the heart rate. So the late decelerations, the variable decelerations, prolonged decelerations, loss of variability, remember, is our oxygenation status, okay? If we have decreased fetal movement, which, in labor, moms don't feel babies move often, and especially if they have an epidural. One of the things that nurses do is every hour or two, I will palpate and try to elicit a baby movement so that I can know that baby is moving. However, an indicator, if I can't catch a baby movement, that doesn't mean the baby's not moving. But if I have normal variability, a normal heart rate, and I have accelerations, I probably have fetal well-being. I probably have a baby that's moving in there as much as they can in labor at term. So anyways, meconium-stained fluid is a huge sign of fetal stress. So that's why babies have meconium in utero, is they're under stress. So that puts us on alert, okay? And then if we have tachycardia or bradycardia, we have that for a reason, and it's not a good one. So we need to address those. I will tell you, tachycardia, you may have tachycardia running. If you do not fix tachycardia, then you will end up with bradycardia. Not so much the same the other way around. So if you have a normal heart rate and then all of a sudden you have bradycardia, you need to fix that. That's not going to go back up typically on its own. It needs intervention or delivery. So tachycardia will be followed by bradycardia. Bradycardia isn't followed by tachycardia. Okay. All right. So what do we do if we have these bad baby heart things? So we do what's called intrauterine resuscitation. We talked about this in our clinical orientation type lab day we had. And the purpose of this is to improve fetal blood flow. Okay? So first thing we're going to do is we're going to turn mom, reposition her, so that we possibly can get any pressure off the cord, or even if there's not pressure on the cord, we can facilitate a larger blood flow to the uterus. Okay? We're going to administer IV fluids, maybe even a bolus, and if you're there at the pump doing IV fluids, you'll turn off the pit at that time. Okay? We're going to administer oxygen, 10 liters non-rebreather mask, period. There is a new mask out there that it's not a rebreather. You do pipe in 10 liters. It gives 100% inspired FiO2, just like the non-rebreather mask. But important thing to know here is it's not a simple face mask. It is not a nasal cannula. Okay. Discontinue the oxytocin if you have it running, and then if mom has a hypotension issue because maybe she had an epidural, then we will address that too. Now, these things, even though they're listed in this order, that does not mean that you're going to do each one of them, and that does not mean that you may not be doing some of them simultaneously. The purpose of centralized fetal monitoring is that we can see the fetal monitors of every patient on the unit. So what happens in OB units is nurses that see some other patient having non-reassuring fetal heart rates, then all these nurses run into your room. You'll have 5 nurses in your room within a minute or so. And so everybody is doing these things, okay? Even anesthesia. So if we have a profound hypotension within minutes of the epidural being placed, anesthesia is there. He's pushing the ephedrine. You're doing your IV fluid bolus. You're changing the patient's position. You're putting oxygen on. You're doing whatever, okay? Other nurses will come in as well. So other things that we can do to get, it says to get more information about fetal status, or to stimulate the baby to have some sort of reactivity, okay? So if you have a flat strip, poor variability, no accelerations, we can do this scalp stimulation. So basically that's a vag exam and you just kind of tickle the baby's head. Or we can do this fetal acoustic stimulation, and it is this little device that we put on the mom's belly. We push the button and it vibrates and makes a noise. It goes eh. So that kind of spooks baby, and they startle, and we have movement, and then hopefully we see reactivity on the strip. But I caution you in doing either one of these things if you truly, truly do indeed have a stressed baby. Okay? Because a stressed baby cannot take any more stress. Okay? So if you just got a baby that's on the fence, or that's just being a lazy baby, you can do this stimulation to try to get some reactivity. But if you truly got a stressed baby, you know you've got a stressed baby, you have all your rationales and your risk factors and all your things telling you, I have a stressed baby, don't stress your baby out even more by doing scalp stim or acoustic stim, okay? Okay, come on. All right. So prolapse cord, another obstetrical emergency. So the water breaks. Either we break it or it breaks on its own. And as that fluid is rushing out of the uterus, so is the umbilical cord. And then as the fluid, that buoyancy leaves the uterus, that head comes crashing down and squishes the umbilical cord. So the only thing to do to make this go away is to relieve the compression off the cord. So you have to do a vaginal exam and you have to push that head up off the cord. You cannot then go and stuff the cord back in. Okay? So you stay there with your hand on that baby's head, pushing that baby's head off the cord while we drive you and mom into the OR. And then we do an emergency C-section. The other thing you can do is you can do a Trendelenburg. If you guys remember, the beds have a setting, Trendelenburg setting, where they can tilt with the head down, feet up. Okay, and this will assist in relieving compression off the cord. So, anyways, she goes to C-section. Done. Okay, so here's a look at how that happens. Okay, so the fluid's rushing out, the cord is rushing out, and then when that buoyancy of that fluid is gone, the head crashes down and pinches that cord. All right. Amniotic fluid embolism, I pray I never see this again. In 20 years, I have seen this one time. And that was just a few years ago here in Missoula. We lost the baby, and the mom survived by the grace of God. And I'm telling you, that's that is the only answer. She should have died, but she was on dialysis. She was her liver was almost ruined. I don't know how she is today. She did survive. I don't think she's on lifelong dialysis. I don't know. I can't tell you. But I know that we eventually shipped her to, she was in our ICU in CMC for a week or so, and then we shipped her to St. Vincent's, and she was there for a period of time, and they shipped her to Seattle. So, so amniotic fluid embolism is the evil of all evils. So we currently now, though, call it anaphylactoid syndrome of pregnancy. I guess it's a more politically correct term. Anyways, it's extremely rare. So like I told you, I've seen it once in 20 years. And that's not saying a lot because, you know, the first 15 years of my OB experience was in a small town, but unfortunately, we never had that incident happen in our facility. If we had that incident happen in our facility in this small town, we probably would have lost both mom and babe. Not so much because we're small and don't know what we're doing, but because we don't have access to the things that kept these women alive. Okay? Maybe we could have shipped her. I live close to Billings, Montana, or I lived close to Billings, Montana, but anyways, maybe we could have shipped her to Billings, Montana, but it's really bad in rural America. But anyways, thank God it is rare. But it frequently happens with either a difficult and or difficult rapid labor. Okay. So what happens is, so all of a sudden your lady's sitting there laughing and talking and having a good old time during your labor, and then all of a sudden, just like someone has a massive coronary, she has sudden respiratory distress, circulatory collapse. She can actually just die on you right that very second. So an emergency C-section needs done, and the only treatment for mom is supportive therapies. So CPR, resuscitation, those kind of things. So anyways, she can have some chest pain, cyanosis. As she starts deteriorating, you'll see tachycardia and hypotension, but it's usually pretty quick. I mean, a lot of times she's sitting up and the next minute she's out, so it's pretty quick. So yeah, so for mom, we just try to resuscitate her and do what we can to keep her alive. And then hopefully for the baby, hopefully we get baby out in time, that they do well. Otherwise they go to NICU and depending on how long mom was out before we got baby out, is the degree in which baby is going to need help as well. Okay? Okay, didn't really cover this specifically, but we've talked about CPD. So the fetus is too big to get through the uterus, or I'm sorry, through the pelvis. For whatever reason, mom has a small pelvis, or maybe the baby's big. Okay, so there's some other problems mom can have, but for one reason or another, either the baby's big or the pelvis is small or has issues. Okay, so if the baby's not coming down into the pelvis, that is going to prolong our labor. Okay, and then as the uterus keeps contracting to try to get this baby down, we're going to risk hurting our uterus. Okay. We may even end up using forceps. However, a CPD is usually a CPD that even forceps can't fix. So the danger of the cord prolapse is the baby never comes down into the pelvis, the water breaks, and then there's your cord. Okay? Then we can cause all kinds of other injuries to our baby, forcing that baby through a square hole. Well, a square baby through a round hole. So these pelvic measurements are great. Estimating fetal size is great. However, they're just estimations and they may not be accurate. In other words, we may be thinking her pelvis is too small when indeed it's not, or we may be thinking her baby's too big when indeed it's not. So even if you do pelvimetry and do estimate fetal size, even if you do determine that it seems like it might be too big, then there's that decision of whether or not to do a trial of labor and see if it happens anyway, or just to go ahead and plan for a C-section. All right, third and fourth stages. So third stage, if you remember, is when, so the baby has been delivered. Third stage starts from the time the baby was delivered until the time the placenta is delivered. And then fourth stage starts from the time the placenta was delivered till about 2 to 4 hours after delivery or postpartum recovery period. Okay, so once we get the placenta out, we need to inspect the placenta, make sure that we got it all, like it all came out, because if she retains placenta, then that's going to cause her to bleed. We need to inspect her for the physician will be doing this, but he'll inspect her for lacerations and then repair those. Now, placental adherence, I've seen this several times. It's not very common, but I've seen it quite a few times where the placenta never does separate. So a lot of times the physician will either try to go in vaginally and remove that in the delivery room, and then there have been cases where we've had to go to OR for the physician to deliver that. So if the placenta hasn't come within 30 minutes, then we need to start thinking of doing something to get that out. Okay. All right. So for cervical and vaginal lacerations, so if the physician has done his repair, or even if he didn't think there was a repair to do and he's left, okay, And now we have this woman who has this persistent bleeding, bright red bleeding. And we've massaged her fundus. It's rock hard firm. We're not expelling any blood as we massage. In other words, as you're massaging, you don't feel like the blood that's trickling out is coming because you're pushing it out. It just seems to be coming, irregardless of the stream, is irregardless of you massaging or not massaging. Okay. So anyways, if that's the case, then we need to pull the physician back in. But when we do use forceps and a vacuum, we increase this woman's chances of having some sort of vaginal laceration or cervical laceration that the physician just didn't see, that he or she missed. Okay. Now, if we do retain our placenta, it doesn't separate. We can go in and manually remove that in the delivery room, and sometimes we need to even go to the C-section room, or the OR, and deliver that. And then it comes out just fine, and then everybody's all good, okay? But there are some conditions where that placenta will not separate from the uterus. So there's 3 different types of placenta: accreta, increta, and percreta. So an accreta is that it's directly attaching to the myometrium, okay? And with the increta, it's actually penetrating the myometrium, increta, so it's going into the myometrium. And then the percreta, it penetrates completely through the myometrium, okay? And so these need to be surgically removed if they can be removed. And if they cannot be removed, she's going to have to get a hysterectomy. And that's terrible. But these can cause... Oops, sorry, I need to pause for a minute. These can cause massive bleeding. Okay, sorry about that. Let me go back really quickly. So when we're talking about these accretas, the accreta, the increta, the percreta, and it's attaching to the myometrium or through the into the myometrium or through the myometrium. Remember, the myometrium is the middle layer. So the placenta is supposed to just adhere to the inside layer of the uterus, which is the endometrium, right? So this is going through and attaching to the middle layer of the uterus, which is the myometrium. So the accreta is just attaching to it, okay? The increta is invading in it, and then the percreta has penetrated through it, okay? So I wanted to clarify that in case you needed a refresher on the layers. Okay, so here's another couple of variations of the placenta that are put these women at huge risks during their pregnancy. Secenturate placenta, okay? So there's usually 2 lobes of placenta. So you can see here in this picture, we have the big placenta, okay? So this is what we should have, period, okay? Nothing else. But for some reason, we have this little other clump of placenta and all these vessels, okay? So this scenario is dangerous for women. It puts her at increased risk for hemorrhage. And then the baby, you know, as long as this still functions for the baby will do fine, okay? But if where's my cursor? If this gets damaged in any way during labor, then we have a bleeding issue, okay? And then when the woman does deliver, until we get all this out of there, she can have some postpartum bleeding issues as well, okay? The next one is the circumvallate placenta. So basically, there's a double fold that forms around the cord, a double fold, I'm sorry, of her chorion and amnion, okay, around the umbilical cord, okay? And so it's hard to see here and to understand, you know, what it's doing, but it just puts her at increased risk for losing her pregnancy, for bleeding, and then, of course, the baby is, depending on this fold and how this fold is affecting blood flow back to the baby, baby can be having growth restriction or small for gestational age or prematurity, and, of course, death, okay? Now, this one looks pretty normal when you look at it, except for this right here. So this is the umbilical cord, and it's here on the edge of the placenta. Okay, it should be here in the center of the placenta. Okay, so this just causes increased issue of bleeding and then problems for baby. Okay. All right, I will go back to this one. We did have a patient with this one, and these vessels were right over the cervix. So she was having bleeding during her pregnancy. And then we couldn't let her deliver vaginally. We had to schedule her for a C-section because we couldn't have baby. This was right over the cervix, so we couldn't have baby coming down and pushing on those vessels. All right. All right. The velamentous insertion of the umbilical cord. This is similar to the first one, the one I told you where the vessels were over the cord. I'm sorry, the vessels were over the cervix. So we have the placenta here, and the cord is supposed to be right here. But for some reason, the vessels are growing out and the cord isn't starting till here, okay? So this is, again, another issue similar to the first one we saw. So hemorrhage, and then, of course, baby having problems as well, okay? These are actually pretty rare. They're not very common. All right, so I don't think, yep, I didn't put any slides for this one, so just review this section of perinatal loss and how to help patients through that. Okay, birth-related procedures. We talked a little bit about diversions. Okay, so this is a little bit of a review. 36 weeks is when we want to do these for a breech presentation. The external version is the one the physician does on the outside of the body. Okay, he tries to move that baby from the outside. So we need to have a reactive NST, and then, well, especially after the procedure to make sure baby tolerated it well. We have tocolytics, so we may or may not give a tocolytic before the procedure, but if she is contracting, then we will, because a lot of women contract at 36 weeks and they're not in labor, but that will, you know, present more difficulty in doing the procedure. So we can give a tocolytic, and then even after the procedure, if after the procedure we do our NST and we see that we're starting to develop contractions that the patient is now starting to feel, we may even give a tocolytic afterwards. And then pain medication before. This isn't very comfortable, so pre-medicate her. Now the internal version is what they would do. So they have a twin gestation that the woman is trying to deliver vaginally. Okay, the first twin comes out head first. The second twin is way up there in the fundal area. Maybe the second twin is transverse. Maybe the second twin is breech if they were side by side. Whatever the case is. So the physician will go in vaginally and try to turn the baby so that she can deliver the second baby vaginally. Okay? So she's 10 centimeters. She's contracting. She delivered the first baby. We may have to give her a tocolytic to relax her enough for the physician to be able to turn the second baby. And then if we've done that, then we may, if we haven't been running Pitocin, we may need to start Pitocin to start her contracting again. This says here that the physician will pull the baby out breech. So a lot of physicians will not even attempt to pull a baby out breech. They will just go ahead and C-section her. That's why when we have a twin labor, we will labor them in the labor room, and then when they get complete and are ready to start pushing, we move them into the OR. And we do that because of this scenario. Many physicians, most physicians will not try to deliver that second twin breech. They will just go ahead and do a C-section. Okay? I do know one physician in particular who will go ahead and try to do a breech delivery, and that's Dr. Fawcett, the perinatologist, and he is very experienced doing that. I have been in the OR when he has done that, and so twins, you usually have smaller babies, so delivering a smaller baby breech is a little easier than, of course, delivering a twin, a term baby breech. So, all right, amniotomy. So this is either to stimulate or to induce labor. So we have a woman that is, so we manually break her bag of waters. If you remember, during hospital orientation, the long yellow crochet hook thingy-majigger, well, that's what we use to break a woman's water, okay? And we do that, one, to induce labor. That can induce labor, so we don't have any pit running at all, okay? We want to induce her labor. She doesn't want pit. She wants to try to do it on her own. We go ahead and break her water, okay? Or she's on pit. She's progressing, but she's progressing slow. We do a vag exam, and we feel this big, huge, bulging bag of water, just like a water balloon would feel. And just to help her labor go a little faster, we'll go ahead and break that bag of water, okay? Because if we can get that big cushion away out from in between the baby's head and the cervix, then yeah, she's going to dilate faster, okay? Now, if we've got ruptured membranes, or if we need to put on an internal monitor for the baby or for her contractions, we can do that. If we need to do the internal monitoring and she's not ruptured, then we'll go ahead and rupture her so we can do the internal monitoring, okay? Obtain fetal scalp samples for pH monitoring of babies. So we don't do this ever at all, but we could do this. But the water does need to be broke to do this, because you need to get scrapings of the baby's scalp, okay? And what this does is you have a baby who has minimal variability all throughout labor. You have a baby who keeps having late decelerations or variable decelerations, and you're thinking that we need to go to C-section because we have these bad baby heart rates. We can't see into the future. We do not know if this baby is going to continue to tolerate labor. Even if baby continues to have those heart rate patterns, will we be able to get baby to a vaginal delivery? We don't know. So to err on the side of caution, we will go to C-section. But this is an opportunity to maybe not go to C-section. So if we have normal fetal pHs, even though we have bad heart rates, then we can continue that labor. But but it's not a common practice. I've never ever seen it done at CMC. I've never ever seen it done in the other facilities I've worked at. So it's they're not feeling like it's very reliable. They're feeling like it's more of a risk of fetal infection, and so they just don't do it. Okay. Anyways, once we break the water, we can now assess for color, composition, and odor of the amniotic fluid. So we want clear fluid. You know, it can be bloody fluid, but we don't want any shade of green or any thickness of green. So you can have green lemonade looking amniotic fluid, or you can have pea soup looking amniotic fluid. Either one of those means that there is meconium in the amniotic fluid. Okay. And we can deliver vaginally. We can keep this labor going even though we have meconium in our amniotic fluid. We just now need to have a NICU team at the delivery. If babies are born and they've had meconium, we need to assess if there's any meconium in the airway. Okay? And if there is, we need to suck it out before the baby takes their first breath. Now, there have been times where we've had thin meconium and the baby is born and the head is born, and before the rest of the body is born, the baby is screaming at the top of their lungs. We pull the baby out, or the baby comes out, and the baby is kicking and screaming and vigorous. Okay? So that means that we do not need to visualize cords. We've got a screaming, vigorous, breathing baby. So it's too late to suction any meconium out of the airway anyway if baby has already taken a breath. So for any baby that's born with meconium, no matter if it's thin or thick, if they come out screaming and vigorous, then we just do normal baby cares, and we will increase our surveillance of this baby in case, well, yeah, the baby did aspirate, and now here in an hour or so, the baby is going to start showing signs or whatever. But if the baby comes out, we deliver the baby. If the baby does not attempt to take a breath, we deliver the baby, we clamp and cut the cord, we hand the baby off quickly to the NICU team. They take the baby to the warmer, they intubate and visualize cords and suction. And hopefully they have done all that before baby takes a breath. So it's a very quick, fast thing. Okay? There you go. For meconium. Oops. All right. Okay, so taking care of a woman for induction. So we can bring a woman in and start her induction. She comes in, we start an IV, we get pit running, we break her water, there you go. But there's some women we want to induce that their cervix is closed, their cervix is thick, their baby seems to be high up in her pelvis. So we need to do something to make the cervix what we call cervical ripening. We need to make the cervix softer. We want it to fill with fluid. We want to break down those collagen fibers, and we want the cervix to be favorable to the effects of Pitocin and contractions and start to dilate. So that's called cervical ripening. Okay, and we'll do cervical ripening for a period of time, and then we will start her induction. Okay, so what we use for cervical ripening, there's a couple of things we can do. We can use, so our pharmacological agents are Cytotec or Cervidil. Cytotec, if you remember, I said a few minutes ago, is the drug that we give for postpartum hemorrhage that we put in rectally. We do 600 to 800 milligrams rectally. Well, Cytotec, we do 25, and we do it vaginally. Okay. Anyways, and then Cervidil is a prostaglandin. It's like a soap on a rope type of thing. It's this little tiny piece of cloth that is the prostaglandin is the Cervidil agent, and then it's connected to a long string, okay? And those things, so they ripen the cervix. The other thing that those things can do is irritate the uterus and cause contractions. It's not an induction agent, okay, but the irritation that it causes makes the uterus irritable, or it makes the uterus contract. Sometimes it can contract so much so that we get a tachysystolic pattern. And remember, that is more than 5 contractions in a 10-minute period. When we use these agents, the women have to be on continuous fetal monitoring, and we have to have IV access, and we do frequent vitals. Usually they're every hour. The IV access does not necessarily mean IV fluids. We just have to have that access in case we need to use IV fluids. I kept saying milligrams. I'm sorry. I'm terribly sorry. Micrograms. Anyways, we give 25 mics every 4 hours until regular contractions. And sometimes that is 1 dose. Sometimes that's 4 doses. But when we get regular contractions, then we can start Pitocin. The Cervidil, on the other hand, is 10 milligrams on that little cloth thing. We put it in vaginally up by her cervix, and we leave it in for 12 hours, and then we pull it out. Now, with Cytotec, if we put that tablet in and we get a tachysystolic pattern, we cannot get the tablet out. So that's where the IV access is important. Then we need to start running fluids and trying to counteract the tachysystolic pattern. With the Cervidil, if we develop a tachysystolic pattern, then we can just pull that out. Okay? And then after the 12 hours, then we can start a Pitocin. Now, there's another thing that we can do for cervical ripening, and I love, 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 love this. It's called a cervical ripening balloon, and it's similar to a Foley catheter. As a matter of fact, before some entrepreneur designed a cervical ripening balloon, we used Foley catheters for this. I wished I would have thought of this, and I would have been very rich. But anyways, so it's the cervical ripening balloon. It's just like a Foley catheter. So we insert that catheter up through the cervix. On a cervical ripening balloon, there are 2 balloons. So when we insert that catheter through the cervix, one of the balloons is now in the uterus. And we inflate that balloon, and it sits on the cervix. And then the other balloon is positioned so that it's in the vagina, and then we inflate that balloon. We inflate those balloons enough that they put pressure on the cervix. And basically squish the cervix. The amount of fluid we insert in each balloon is really dependent on how much discomfort the woman can tolerate, because it is uncomfortable. And that can be 40 cc's to 60 cc's in each balloon. And then so if we didn't have the cervical ripening balloon, we would use a Foley. We would insert it in through the cervix up into the uterus. So when we inflated that balloon, we would inflate that balloon. We would pull tension so that it's sitting on the cervix in the uterus, and then we would tape that to her leg so that we maintain that tension. All right. The great thing about these is they do not require continuous monitoring. I do know some physicians that put these in the office and send the patient home with the instructions that labor instructions, education on signs of labor. We remove these after 12 hours, and then we start Pitocin. Now, hopefully, a lot of times what happens is that pressure that we put on that cervix is so beneficial that it ends up dilating her cervix, and the catheter falls completely out of her vagina right onto the floor. And usually if that happens, we tell them to come in. We check them, and they're 3 to 4 centimeters. And we can break their water or start Pitocin or whatever. So these are really great. Excuse me. Another method is stripping of the membranes. Physicians do this in the office and send the patients home. But basically what they do is they do a vaginal exam, and they get up there to the membranes, and the purpose is they're trying to separate those membranes. So you remember the bag of waters is actually 2 membranes that are kind of like right next to each other. You really can't see a lot of difference in them, but there are 2 membranes, and one's the amnion, one's the chorion, remember? So anyways, he's just twisting those around and trying to just cause a little bit of a separation in those linings. And that then releases hormones, causes irritability, and hopefully she starts contracting and going into labor and then comes in. Okay, it doesn't require any monitoring. Like I said, the doctors do this in the office and then send the patient home. Hopefully it works. Usually we get patients like they went to the office, and we get the patients by midnight, or in the wee hours or late hours of the night, or in the wee hours of the morning. Okay, so this is a great option as well. Now when we do our induction, we use Pitocin. Okay, Pitocin causes frequent strong contractions, so that requires them to be on continuous monitoring so that we can assure that we're not creating a tachysystolic pattern, or that we're not creating a uterine rupture. Okay, so you slam that Pitocin in on a uterus and you just might burst it. But anyways, so continuous monitoring. There is a very stringent protocol for titrating the Pitocin. So we want to get to a contraction pattern of contractions every 2 to 3 minutes, or 5 contractions in 10 minutes. So depending on the protocol of the facility, you'll start your Pitocin at a rate of 2 milliunits per minute, which equals 2 cc's per hour. We have pre-mixed bags of Pitocin that are in the correct concentration to run at 2 cc's an hour and give 2 milliunits an hour. And then our increasing protocol is to increase 2 cc's an hour, usually every 30 minutes. You'll have a physician say, do a slow dosing Pitocin protocol. You're trying to, and usually, so this is another form of cervical ripening, is a low dose, slow dose Pitocin protocol. So like we get this woman in, she's not in labor, it's 10 o'clock at night, the physician says do a slow and low. So we get the Pitocin going. We started at 1 milliunit, which is 1 cc, and we increase it 1 every hour. And we do that all night long, okay? And then by morning, depending on when you started it, she's at 6 to 10 milliunits, and then she's probably just starting a good contraction pattern. But that slow and low is just enough to give her just enough contractions to kind of, what I say, knock on the cervix's door. Knock, knock, wake up. It's time for you to start getting ready. We're going to start going into labor. This is similar to what your body would be doing at home without you really even knowing it. Like you're having Braxton Hicks contractions, but now these are changing to very early labor contractions, where you having these mild contractions every 10 minutes that are only lasting 20 or 30 seconds. Basically what it's doing is it's saying, hey cervix, wake up, let's get prepared, we're going to go into labor here pretty quick. So, but anyways, it's a very stringent protocol where we increase 2 cc's an hour about every 30 minutes. So every 30 minutes we need to assess our contraction pattern and our fetal heart rate, and our maternal vital signs. Okay, and if all those check out, then we can increase. Now, when you're using Pitocin, and even if you're not using Pitocin, even though we have that monitor on her belly telling us when her contractions are and how long they're lasting, do you remember me saying it's not a good indicator of how strong they are? So we need to be palpating her uterus to see how strong her contractions are, and we definitely need to be doing this every 30 minutes when we are assessing everything else when she's on Pitocin, unless we have that intrauterine pressure catheter in, and that is telling us accurately how strong these contractions are. But anyways, so we need to monitor our contraction pattern, our fetal heart rate, and our mom's vital signs. Now, if we start developing a contraction pattern that is heading to tachysystole, we're creating more than 5 contractions in a 10-minute period. If we're doing that, and our fetal heart rate is still reassuring, in other words, our baby is not having any bad reactions to that contraction pattern, we don't need to turn the Pitocin off. The protocol is to now cut it in half. So if we were running Pitocin at 6 milliunits per minute, which is 6 cc's an hour, then we need to turn it down to 3. Okay, so that's cutting it in half. And then we continue to follow our protocol. We assess our contractions every 30 minutes. If we have an adequate contraction pattern, we don't touch the Pitocin. We just leave it where it is. If her contractions are not adequate, we bump up the pit. If they are adequate, we leave it alone. If we have too many contractions, we cut it in half. Okay? But then the other thing we look at is our baby. What does our baby tell us about the contractions? So if we're not having any fetal distress, we're having a good reactive strip, then yes, indeed, we can bump up the pit. But if our baby starts having problems with late decelerations, minimal or absent variability, tachycardia, bradycardia, prolonged decelerations, things like that, then we turn it off. We just turn it off. It doesn't matter what our contractions are doing. If our baby says stop, then we stop. Okay? Then we wait 30 minutes. And if our baby has recovered, guess what? We get to start Pitocin again. But we have to start over. We have to start at the beginning at 2 milliunits or 2 cc's an hour. Okay? But if our baby at 30 minutes says, yeah, no, I'm still not ready, then we leave it off until our baby gets ready. Okay? All right. Let me think if there's anything else I need to tell you. I think that's it. Now they're on continuous monitoring for this, and that does not mean that they need to stay in bed. They can get up and walk around. We have telemetry monitors where we can still monitor patients while they're walking in the hall, while they're sitting in the jacuzzi, while they're sitting on the birthing ball, whatever. Okay? The only caveat to walking is if she has an epidural. So if she has an epidural, she's not getting up. All right, episiotomies. So episiotomy is when the lady is pushing and the physician cuts into her perineum to make a little bit more room for the head to deliver. There's when we do this, most women have an epidural, and if the physician does this while she's pushing, most of the time she doesn't even feel this. But a lot of times they can use lidocaine, numb up the area, and then cut the episiotomy. There's 2 different types. There's the midline, which is just the way it sounds. It's straight down through the perineum. And then there's the mediolateral, where they start at the fourchette or the lower border of the vaginal introitus, and they cut to the side. Okay, let's see what those look like. So this is your midline, and this is your medial lateral. It could be on either side. Okay. So then after delivery, the physician stitches those up, and then when we do our Q15-minute blood pressure, heart rate, respiratory rate, fundal check, bleeding check on mom, we do that every 15 minutes times 4. We're also checking that episiotomy site, making sure that it's not like bleeding, that we need to have physician come back in and do some more stitching, and to make sure that we're not swelling up with a hematoma. A woman can lose a lot of hematoma in that, or I'm sorry, a woman can lose a lot of blood in those tissues, almost to the point of qualifying for postpartum hemorrhage, even though it's not a hemorrhage that's bleeding from her uterus, but she is bleeding and falling and losing too much blood and falling in that hemorrhage protocol. But anyways, usually we have ice on these women immediately after delivery to help with the soreness, the tenderness, and swelling. Okay, we do also have other things available to mother to put on her ice pack or peri-pad to help with comfort and healing. One is Tux pads that we use for hemorrhoids, perfect for episiotomy laceration pain. And then they have this, I don't know what they carry at St. Pat's. It might be the same thing, but it's just a it's called Nuprocaine gel. It's kind of like a hydrocortisone type of cream that you put right on the pad that helps with inflammation and healing and pain. And then we offer women this little squirt bottle. So we fill it up with warm water. You can fill it with warm soapy water, and when they go to the restroom, they can be squirting that on their perineum as they're urinating to help cut the sting of the urine and the episiotomy site. And then that's a way for, it soothes that area. It's kind of acts like a sitz bath type of situation. They can clean themselves off. We instruct the women that when they wipe themselves to pat dry and not to wipe, because we don't want them damaging that episiotomy repaired site. The other thing we have to offer for women is a lidocaine spray. It's called Dermaplast, and it kind of stings when it first comes on. It's a spray, like an aerosol type spray, and it numbs. So it's a topical numbing agent, and they can spray that before they go to the restroom. They can spray that after. They can be sitting in bed and spraying themselves every 10 minutes if they wanted to. They can just keep spraying themselves to help with comfort. Okay. Okay, so we'll talk real quick about forceps. So here's your indications for forceps. Why do you think, I wish I was with you, why do you think heart disease, pulmonary edema, why do you think we would use forceps in those instances? Okay, so the pressures that's being created to push a baby out will put these women at risk if they have heart disease. It might cause a problem with their heart disease, with their pulmonary edema. Of course, with exhaustion, she just can't push anymore, so we're just going to help her. Fetal stress, so we're pushing and pushing and pushing. Women can push up to 3 hours. I've seen women push a lot more, and I'm not even going to tell you out loud how much it is, because it would shock and appall you as it did all of us. But women can push for an astronomically long time. Okay, but even if they don't push for an astronomically long time, if the baby is starting to say, "I'm done, I'm through, I'm toast, I'm not doing this anymore," and we need to get that baby out, and she can't, we need to get that baby out like in seconds. If she can't do it, then we use the forceps. Okay. And here's how it's done. So forceps, they're two blades. They're called a blade. They're called a blade. They're two blades. The physician will slide one blade on. They'll slide the second blade on, and then they'll connect them together. So when he closes those handles together, then they lock around. There's a little locky thing here. Okay, so they lock around that, and then when he squeezes those handles further, then we get more squeezing here on the baby's head. So this is the correct position. This is where they need to be. Okay, they can't be over the ear. They can't be down here on the cheek. They can't be over here mucking up the eye. Okay, and so when the woman pushes, the physician also applies gentle pulling pressure. Gentle. Now this is the one time when gentle is actually correct. We don't want him yanking these babies out. They can cause severe trauma to these babies in all kinds of ways, not just right here. And I'll tell you a horrible story. But anyways, as she pushes, then the physician pulls a little bit, okay? And then when this baby is born, this baby will now qualify for a regular head measurements. So like they do it every 6 hours to make sure that we didn't cause enough of a bruising to create a hematoma that is growing. Okay, so that's why we're measuring. Okay, so here's my terrible story. 2 summers ago in Texas, this was a this was on national news. It was all over Facebook. There was all kinds of donation type things going on all over Facebook. And but anyways, this physician put a set of forceps on a woman who initially asked to have a C-section. This woman was 4'11". Her baby was estimated to be, I can't remember how big baby was estimated to be, but the woman asked for an elective C-section. The physician refused. She went into labor. I don't know if she was induced or just went into labor, and she got to pushing, and the baby got stuck. And he put a set of forceps on. He sat in his delivery chair. He put his feet up on the bed, and he pulled. And he severed that baby's spine. And that baby, of course, died. So, if you're the nurse, you don't ever let your physician lean back. You don't ever let your physician put his feet up on the bed. You make him do it right. Anyways, okay, enough of that. Oh, okay. So here's your risks to your baby. Okay. Here's your risk to your mom. And those are all pretty evident. Okay, now we're going to talk about the vacuum. One more thing about the forceps. So this is a really intense skill to learn. And as I see newer doctors coming out of school, coming out of their residency, they're not getting a lot of training in the use of forceps. Some of the older physicians still use forceps and prefer the forceps, and now this younger generation of physicians are not getting the training and the skill with the forceps. So I think they have a criteria of the training they need to have to be able to use forceps, and then the continued use in practice to keep their skill competent. So it's just not happening, and so forceps are going out of use. We do see the use of forceps a lot in the OR in a C-section. You would not imagine how often babies get stuck in a C-section. Like when I first was nursing, I was like, why can you not get that baby out of there? My goodness, just lift that baby out of there. But there's such a suction, and babies can be so wedged in there that it is very difficult to get them out. And the head is the biggest problem, like just getting that head to pop out of that incision. So they do put forceps on, even in the OR, for a C-section, and they also use this vacuum. So this is another way to get the babies out, okay, is this vacuum extractor, okay. These cause a huge risk to bleeding, and I'm going to tell you all about that here. So look at this. So this is a little suction, a little plastic soft. It's plastic and soft. We used to use a metal one back in the day, and our suction was on a cart, and we called it the Hoover. Anyways, we had to plug it in. It was electric. It was just barbaric. But anyways, here's nice soft. This is a handheld device. I wish it showed the rest of it. Back here is this little deal here where the physician pumps up the suction, okay? And then there's a meter on there. There's a green area. There's a white area where there's no suction, and it's divided off incrementally in measure. And then there's this green area where they can be with their suction, and there's this red area where they cannot be with their suction, okay? It's too much suction. Anyways, you put these on, you create the suction, and then as the woman pushes, the physician just applies gentle pressure. And as the head is delivered, then the physician will rotate this suction up to help continue to deliver the baby. Now, sometimes when they put this on, the physician pulls a little too hard and it pops off, okay? That's traumatic for the baby's skull and puts the baby at increased risk for bleeding. And so does this suction parameters back here. So they get 2 pop-offs. If they've popped off twice, they never get to apply this to the baby's head again. You need to stop them, okay? But the physician gently pulls as the woman pushes. And gentle, again, is correct in this instance. So you can see how that goes, okay? And again, these babies, just like the forceps babies, they're going to get those head measurements every 6 hours for 24 hours to make sure that there is no developing, growing hematoma. All right. Cesarean, just going to run through this quickly. Most common indicators for cesarean are fetal distress, active genital herpes. So if your woman is positive for herpes, she can still deliver vaginally if she does not have active lesions. So you need to do a visual inspection. If you see active lesions, she cannot deliver vaginally. She has to have a C-section. Okay, multiple gestation. So like I think I said in lecture the other day, a twin gestation can deliver vaginally, but anything above a twin must have a C-section. Okay, umbilical cord prolapse, birth canal problems, failure to progress, dysfunctional labor. What was the other reason I just thought of here? Oh wait, is it here? Maternal infection, CPD, of course, placenta previa, so the partial or complete previous C-section. They don't have to have another C-section, but that is another indication. Some facilities will not allow women to do a trial of labor after C-section, okay, because they don't have the staff to cover the standards. They have to have a complete OR crew in-house during her entire labor, and some facilities don't have that ability to provide, okay. We do here at CMC and St. Pat's. Let me go back here just 1 second. Uterine prolapse. I'm sorry, umbilical cord prolapse. Man, something went through my head that wasn't on this list. Multiple gestation, fetal distress. Gosh, I'm sorry. I don't know what it was. Maternal infection, CPD, previa. Maybe it'll come to me. Anyways, so we bring these women in for either a scheduled C-section or they are going to get one because whatever, labor didn't go well. We need to have an IV running. We need to do a CBC and type and screen. We need to do a pubic hair shave. We need to do an abdominal prep, which is a special soap, a pre-surgical soap we use. And then we need to place a Foley catheter. And usually these are placed after the spinal is put in. And then, of course, all your consents and all that kind of stuff, all your admission and all that kind of stuff are done. Then they go back to OR. They get their spinal placed. We lay the patient down on the table. We do a quick fetal heart rate check. We do a sterile abdominal prep. We put the Foley in, do the sterile abdominal prep, and then she's ready to go. There's a couple of different ways they can cut this C-section incision. The most common, the most common type is this low transverse incision. Okay, and then you can see. So this is low. So they cut this, and then the physician, someone's pushing up here. Only time you're going to be doing fundal pressure, because you're not trying to push the baby through a bony pelvis. So you push out here to try to push the baby's head. Oops, out. Okay. This is the other one. I don't see this one very often. Shoot. Which way am I going? This is the most common. Okay. And then they can do this vertical one, but I don't think I've ever seen a physician do this one. It's always the previous one. Okay. This is the one you do for an emergency C-section. Like if the physician doesn't feel he has time to do that lower one, it takes a lot longer. To get baby out. This one you just slice right down through, you pop baby out. This is the one they do for an emergency C-section. They call this a classical incision. Okay, just imagine. Okay, just imagine we did. This wasn't a stat C-section. It was just a C-section. We did our incision here. Okay. We're trying to get baby out, trying to get baby out, trying to get baby out, trying to get baby out. Something happens that makes us feel like this is taking too long. Maybe she's starting to bleed. Maybe mom's starting to crump for some reason, respiratory, heart rate, blood pressure status, something. And we can't get the baby out, and the physician is feeling like it's becoming emergent, then he will cut this classical incision all the way up from the lower one, and that basically is an anchor. And I've seen that about 3 times in my career. Anyways, care after birth is one. She's a post-surgical patient. Okay, so she's going to have all the normal risks and care that a post-surgical patient would have, with the additional uterine hemorrhage, postpartum hemorrhage type situations. Oh yeah, this is good to point out. So a patient can have a vaginal delivery after a C-section unless it was a classic or anchor uterine incision. Okay, they cannot do a vaginal birth. Those incisions, the anchor basically, because it has the classic component. So if you, let's go back and look. So this uterus contracts so hard during labor that if you put that contraction on this incision, you might rupture this incision. Okay, it's less likely to occur down here. Okay, the contractions down here are not the same as contractions up here, and these have a high risk of rupturing that incision. The contraction has a high risk of rupturing that incision. Okay. All right. So, anyways, oh, what is that? I don't even know what that slide is for. Oh, this is probably what it's for. So if we do have a woman that is going to do a trial of labor after a C-section, then she needs to be on continuous monitoring. She's a high-risk labor now. She needs to be on continuous monitoring, internal monitoring if you can do it, but it's not a requirement. Of course, she's going to have IV fluids. It says to avoid Pitocin if at all possible, but, you know, for whatever reason she had the C-section, if she had the C-section for failure to progress, it's likely that she's going to have that complication with this labor as well, so we might need to use Pitocin. But anyways, we can use Pitocin on a trial of labor person after cesarean section. We just need to be very cautious. Okay, we even need to be very cautious using an epidural because we don't want to mask. We don't want to mask the signs of a uterine rupture, and that is the risk with a trial of labor after C-section. Okay. Oh my gosh! So we're finished. I'm sorry this was so so long. My goodness. But thank you for your patience, and I will see you next week.